First, I'd like to start by thanking the course organizers for the kind invitation, and especially my friend and brother, Dr. Imad Al-Jahdali. It's an honor to be here today among such a distinguished group of speakers for this inaugural GI Cancers Conference in the beautiful city of Jeddah. Harvard was my former affiliation. I moved to the University of Cincinnati now, and this is the University of Cincinnati Medical Center, where I'm fortunate to work with an amazing group. These are my disclosures, and these are our learning objectives today. To cover these objectives, I'll go quickly with a brief introduction on cholangiocarcinoma, and then we'll move from there to cholangioscopy and the role of cholangioscopy both in diagnosis and management of cholangiocarcinomas. Cholangiocarcinoma is cancer of the biliary tract that arises from the epithelial cells of the extra and intrahepatic biliary system. It's relatively rare, representing only 3% of GI cancers. The incidence in the United States is low. It's like 1 in 100,000 of population, but this figure is about 30 times more in Asia, specifically in China and Thailand. Cholangiocarcinoma is both classified anatomically and based on the pattern of involvement of the bile duct by what's known as the bismuth-correlate classification. On the anatomic level, cholangiocarcinoma is either intrahepatic or extrahepatic. The extrahepatic cholangiocarcinoma affect either the perihilar region or the distal bile duct. Perihilar cholangiocarcinomas are so important because they account for up to 60% of cholangiocarcinomas, while distal cholangiocarcinoma account for 35%. Isolated intrahepatic cholangiocarcinomas are rare. They account for less than 5%. And this is something that we should remember when we are investigating those incidentally discovered intrahepatic strictures on MRIs. Isolated intrahepatic cholangiocarcinoma is really very rare. Cholangiocarcinomas of the perihilar region, which account for the majority of cholangiocarcinomas, as we mentioned, are further classified according to the pattern of involvement of the hepatic duct based on the bismuth-correlate classification that was created by Henry Bismuth and Ronald Correlate in the 1970s. Cholangiocarcinomas are important to us as gastroenterologists for two main reasons. The first reason is that there is global increase in the incidence of cholangiocarcinoma for reasons that are not very clear, but it can be attributed to several factors. Things like increasing incidence of MAFLD, metabolic associated fatty liver disease, and maybe also because of the better diagnostic tools that we have nowadays that help us to diagnose these lesions early on. The second reason is that they are often present at a late stage. So only 20 to 30% of patients being eligible for curative resection at the time of presentation. And that means that the majority of patients with cholangiocarcinoma will end up getting some palliative therapy that's accompanied by endoscopic biliary drainage, or ERCP. Cholangiocarcinoma also poses a lot of challenges on both the diagnostic and the therapeutic levels as well. On the diagnostic level, indeterminate strictures are headache to interventional endoscopists since they often require multiple procedures and repeated sampling. While on the therapeutic level, there are several challenges, whether it's the intrahepatic strictures that are more technically demanding to traverse and stent. The patients typically require repeat procedures, especially with better chemotherapies. Patients are surviving for longer time, so they need more repeated procedures. And in the meantime, these patients are at high risk of developing cholangitis, which can be a serious complication for the procedure. And the last thing also that can face us is unexpected technical issues in these patients if they have an altered upper GI anatomy that will present in one of our cases today. So managing cholangiocarcinoma is not easy. It requires collaboration between multidisciplinary teams along with patients' persistence and determination to beat this deadly disease. My presentation today will be based on a real life story of one of my patients who is very hard to forget. One morning, my advanced endoscopy fellow got a consult about a middle-aged, pleasant female patient coming to our ER with painless jaundice. Her story is kind of sad. She got an uncomplicated Roux-en-Y gastric bypass surgery just 3 months ago, and she was happy with the outcome. She started losing weight as expected, until the last couple of weeks when she started noticing mild discoloration of her eyes, yellowish discoloration. And then the morning she came to the ER, when she woke up, she was so yellow that her husband decided to bring her to the ED. In the ER, her labs were consistent with obstructive jaundice. The ER did a CT scan that showed intrahepatic biliary dilation and an MRI that showed this. An intrahepatic perihilar stricture with intrahepatic biliary ductal dilation, of course, highly suspicious for cholangiocarcinoma. We discussed with her that her Roux-en-Y gastric bypass anatomy will even complicate her procedure more, and unfortunately, we will have to at least temporarily reverse that anatomy with an edge procedure to be able to do an ERCP. She was fine with that, and we typically in these procedures start with an EGD scope just to verify the anatomy, typical Roux-en-Y, and then we switch to an EUS, a linear EUS to identify the excluded stomach, the gastric remnant, and then using a 19 gauge needle, we puncture the remnant, fill it up with a mixture of saline, methylene blue, and contrast, and verify under fluoroscopy that we are targeting the excluded stomach. Once this is verified, we switch to the lumen-opposing metal stent, electrocautery to puncture the stomach wall, and now we're deploying the distal phalange of the lumen-opposing metal stent, or the Axios stent in this case. Once this is deployed, the proximal phalange is deployed under endoscopic guidance, and then once this is done, we switch to an EGD scope to dilate the lumen-opposing metal stent to the maximum diameter. In this case, it was 20 millimeters of diameter. We use a standard dilation balloon, CRE balloon, under fluoroscopy. And then once the stent is dilated, we go through it with the scope to the excluded stomach to verify the anatomy before we switch to ERCP. We switched to ERCP, cannulated, and got a cholangiogram, which basically confirmed what the MRI showed, a perihilar stricture. Once this is confirmed, the next step is to obtain samples from that stricture. The first option that we still perform as a standard of care is biliary brushings for cytology. Brushings have several advantages. They are easy to perform, they are readily available in most endoscopy suites, and they are inexpensive. So that's a great advantage for biliary brushings. But it's important to remember that the diagnostic yield of brush cytology alone does not exceed 50%. That means that 1 out of every 2 patients with cholangiocarcinoma will be missed if we just perform cytology alone. The good news is that in those patients that brush cytology is positive, the specificity is really high, close to 100%. So getting this cytology report is not a surprise with biliary brushings for cytology, but it adds to the confusion and challenge of diagnosing cholangiocarcinoma. So in addition to cytology, we routinely obtain brushings for fish as well. Of course, the one on the right, not the one on the left. And fish cytology, or fluorescent in situ hybridization, relies on specific DNA probes to detect mutations and abnormal number of chromosomes. Adding fish to brush cytology will increase the sensitivity to about 60%, with very minimal effect on specificity, which is good improvement, but still not enough, especially in a deadly disease like cholangiocarcinoma that cannot be missed, a disease where basically early diagnosis can be the difference between patient going for curative surgery and going for hospice. And that's where the role of cholangioscopy comes up. Single operator cholangioscopy or what's commercially known as a spyglass, one of the commercially available systems, is a catheter-based system where a single endoscopist can control both the duodenoscope and the cholangioscope. And the most recent platform allows for high-definition imaging, which helps with detection of mucosal abnormalities in the bile duct. It provides direct visualization of strictures, and it allows for targeted biopsies, and these factors together would reduce the need for repeat procedures. This superior visualization of current cholangioscopy platform allowed for better diagnostic criteria based on mucosal abnormalities. So now we have the Monaco criteria and the CRM criteria to help with diagnosis. The CRM criteria relies on detection of mucosal and blood vessel patterns that are either consistent with neoplastic lesion or a non-neoplastic lesion, looking at the villus pattern, the polypoid pattern, if there is an inflammatory pattern. Things like spider vascularity and ulcerated mucosa can be signs for neoplasia. The CRM classification has high sensitivity and specificity, but like any visual classification system, it's operator dependent. The more you do, the more you recognize these lesions, so it's very operator dependent. The other classification system is the Monaco classification that was put together by Michel Kehela and his group, and it helped to classify benign versus malignant findings on cholangioscopy. Findings like presence of a stricture, presence of an intraductal mass, and how much does it occupy, mucosal features, papillary projections, ulcerations, and the blood vessel pattern as well, all put together can direct us towards suspicion for malignancy. Going back to our case, we performed cholangioscopy. And you can see here there is an intraductal mass that's occupying most of the bile duct, causing a stricture with an abnormal vascular pattern that is suggestive of malignancy. The benefit of cholangioscopy is that in the same time it allows us to perform visually directed biopsies from the areas of suspicion, which we would see that would help with the diagnostic yield. Cholangioscopy-guided biopsies will increase the sensitivity to above 70% with a specificity of 100%. So it's kind of good improvement when we compare it back to just brush cytology. Before we move from diagnosis, it's important to remember that EOS FNB can cause tumor seeding in cholangiocarcinoma, so it's not an option for operable candidates and should not be the first-line modality unless we are sampling a suspicious lymph node. And I'll leave it here for you to stay tuned for the great talk by my colleague, Dr. Abed Al-Lahabi. I think he's going to be discussing this in detail for the role of EOS in cholangios. Cholangioscopy has not only improved our diagnostic tools for cholangiocarcinoma, but it also improved our therapeutic options for cholangiocarcinoma. It enabled us to perform selective intrahepatic cannulation. Also, we can perform intraductal ablative therapies, things like photodynamic therapy and radiofrequency ablation. And recently, it's been used by surgeons to determine the resection margin during surgery. When it comes to selective cannulation, cholangioscopy can help us determine an orifice where we want to direct the guide wire, cannulate irregular and extensive strictures, which are not uncommon in cholangiocarcinoma. And that would spare patients more invasive procedures like EOS-guided biliary drainage or PTBD. We can also offer patients now intraductal ablative therapies like RFA and PDT. PDT destroys tumor tissue through the interaction of locally applied light with an IV photosensitizing agent that's preferentially absorbed by neoplastic tissue. PDT improves survival when added to standard endoscopic management. Actually, a large randomized control trial of 39 patients was prematurely halted due to the increased benefit of PDT immediately seen in their population.
2 minutes left.
Okay. The median survival for the PDT group was 493 days compared to 98 days only for stent-only group. That's basically 5 times longer survival than the stent-only group. PDT has limitations. It's expensive, often not covered by insurance, and it requires patients to avoid sunlight for prolonged periods. The more commonly used intraductal ablative therapy is RFA, which uses heat energy from a bipolar probe to induce tissue necrosis. This is introduced over a guide wire. The probe is made up of 2 8mm probes separated by an 8mm spacer. We typically perform cholangioscopy first to look at the mucosa, identify the margins where we need to do the ablation, and then we introduce the probe over the guide wire. The RFA settings depend on the generator used. And just to kind of summarize, basically for extrahepatic lesions, we use higher settings. For intrahepatic lesions, it's